Rachel. I was for a long time working in the Echo Lab at Washington Hospital Center, and a couple years ago I moved up to Union Memorial and Good Sam Hospital, but I miss all of my friends down at Hospital Center, and I miss working with the amazing fellows. So I'm glad to, sorry I can't see you, but hi, it's nice to meet you. I'm going to talk today about Chagas disease, which I imagine you might think is a zebra, and I'm going to try to convince you that it's not, particularly working at Washington Hospital Center, where there's a very large Latin American immigrant population that's at risk. So I'm going to start off right now. Oh, actually, I should also say that I am the medical director of the Latin American Society of Chagas. It's a nonprofit that works in the DC metropolitan area to raise awareness of Chagas disease, both in the at-risk community and in the medical community. But also we screen Latin American immigrants for Chagas, and I have a clinic that does basic cardiac testing for them for free. And we also will treat select patients with antiparasitic therapy who need it. And I'm sort of a Chagas agitator, so I don't know actually if any of the fellows have been agitated by me before, but I also like to go looking for Chagas disease in patients who I saw in the Echo Lab who I thought might have Chagas, with great success, actually. So I'm going to start off with a patient testimonial. Oops, that's my, oh, I forgot about my Zorse. So I am going to tell you that I think this is probably not exactly a horse that you, when you hear hoofbeats, you should think horses. It's not going to be that common, but I do want to make sure that you think about it because it's not anywhere near as rare as you might think. And it's definitely a disease that you're going to see at Hospital Center. Okay. So this guy, if I can get my homemade video here to work, this is a patient who is a Washington Hospital Center patient. I will let you tell him a little bit about himself. You may even have seen him in clinic in post-transplant setting. So.
48 años de edad y he sufrido mucho acerca del corazón y luego fui al médico y me detectaron que el corazón necesitaba un trasplante de corazón, pero mientras eso esperé un órgano mucho tiempo y luego mientras yo esperaba el órgano estuve con un aparato para sobrevivir y luego cuando salió el donante entonces me lo pusieron, pero tomo muchas medicaciones para poder sobrevivir, para que no rechace mi cuerpo al órgano.
So that, I think, was a really powerful testimonial as to why it is that we need to pay attention to this disease. It can be catastrophic in its complications, and also a testimony to the fact that we see it at Washington Hospital Center. So what is Chagas disease? I'm not quite sure what you learned about in medical school, but unfortunately, I doubt it was very much different than what I learned about in medical school a zillion years ago, which is that Chagas disease is a parasitic infection that causes long-term heart damage and gastrointestinal damage, chiefly transmitted by rejuvid bugs to a mammalian host, and there are over 100 reservoirs known. That matters just because it's a zoonosis, and it means it can never actually be entirely eradicated because there will always be some other mammalian reservoir. It's traditionally thought of as a disease of rural Latin American poverty, and this is where it gets tricky because people think about it as only being in Latin America, in which a domiciled nocturnal bug feeds on sleeping victims, lives in cracks and crevices of poorly built houses, and chicken coops. These are some examples of the kinds of houses that somebody might have lived in if they were exposed to the bug and the vector in rural Latin America. And one of the things that you can see is that it's really very different than the kinds of rural poverty that we have here. We don't tend to have these kinds of houses with very poor plastering, no windows at all, palm frond roofs. In some of these houses, there's actually really not much in the way of walls altogether, which means that there are, the domestic animals can walk in and out of the house. They have Chagas disease, the bugs have Chagas disease, the humans have Chagas disease. It's just sort of a mosh pit of Chagas disease. So this might be what you might find in one of these houses. Somebody's pulled the plaster off of the wall and you see these two insects here that are the rejuvid bugs. You also see these black streaks. It's actually fecal material, and that becomes important later on. So this is really where in the world we have Chagas disease, all of these orange spots, and you actually see, well, here's lots of Latin America, here's Central America, notably not the islands, not in Puerto Rico, Cuba, or the Dominican Republic, but whoa, look at that, the lower half of the United States. So it turns out that we actually have both the bug and the parasite there What I'll tell you is that the risk of getting Chagas disease in the US is quite low. We could talk about that another time. I'm really going to be focusing mostly on people who were born in Latin America and came to the United States with this disease. So here's what happens. This is one of those triatomine insects. It's about the size of a quarter when it's an adult. You can see that it has this very long, thin proboscis. And what's interesting about it is that I think there's an anesthetic in it. And so in general, people who've been bitten by this bug don't really remember it. This bug is getting fatter and fatter and fatter as it has its blood meal. And then it has a gastrocolic reflex. And here is its poop. And its poop has the parasite in it. So the way that this disease is transmitted is not by being injected in the saliva, which, for instance, like malaria. It's that the infected fecal matter gets rubbed into the bite wound or into the eye, usually by the unsuspecting human who this insect is biting. Here's an example of the parasite. It's Trypanosoma cruzi. There are actually two different main strains, Trypanosoma cruzi 1 and 2, and they're substrains. In general, people say that Trypanosoma cruzi 1 and its substrains are more likely in Central America and Mexico, and 2 in South America, although there is some cross breeding, and so that's not a precise definition. So here's what happens. The parasite gets into the bite wound and then it spreads hematogenously to the end organ tissue, which includes smooth muscle cells in the myocardium, in the viscera, including the esophagus and the colon, and autonomic nerve termini. And here they all clustered inside a cell. So it's an intracellular parasite. What will happen sporadically is there'll just be too many of them. The cell will burst open, the parasite will get back into the bloodstream and reseed everything all over again. So what does the parasite do? Well, there's actually 4 main mechanisms for the pathophysiology of Chagas disease. They all coalesce on myocardial damage and fibrosis. The first thing is that even decades after infection, people actually still have the parasite living inside their heart. We know this because of PCR technology, and we also know this because if we transplant somebody, give them immunosuppression, they're going to reactivate. And what you find are parasites with lymphocytic infiltrate around them. So this is a lymphocytic myocarditis. The parasite also causes microvascular abnormalities, including intimal proliferation, endarteritis, abnormal vasodilatation, and then consequent watershed ischemia. There are autonomic derangements, particularly because of the parasite tropism for the autonomic nerve terminus, and immune-mediated injury. For a while, people actually thought this was the main mechanism of disease because in a chronically infected person, it was very difficult to culture parasite from the bloodstream. So they thought, oh, it must be autoantibodies. Well, there actually are autoantibodies against beta adrenergic receptors, but it's not the sole reason why people develop this pathophysiology. So those are the sort of the 4 main mechanisms there. Here are some examples of some hearts that have been damaged by Chagas disease. And this is really going to inform the clinical presentation. So this first heart here is a very dilated heart with focal scarring at the apex and thrombus formation at the apex. So this is in all likelihood a patient who died from congestive heart failure, may or may also not have also had a stroke. Here's another heart. This is a heart where the myocardial tissue looks much healthier, but you see this focal apical aneurysm. You might imagine that this patient had normal left ventricular function, but they do have this classic pathophysiology of Chagas disease, which is a focal apical aneurysm that can develop thrombus and can cause stroke in patients who otherwise you would not worry about it because their LV function is normal. This is an example of somebody who also looks like, for the most part, their myocardium is nice and thick, except for this part here, which is the basal inferolateral wall. This is thought to be as a result of watershed ischemia and its focal scar formation. This is unfortunately intensely arrhythmogenic, and this patient may also have had normal left ventricular function, but experienced a sudden cardiac death event on the basis of this wall motion, or of this regional wall motion abnormality. And this last image here is of the His-Purkinje system. This reminds me that there are more than just tachyarrhythmias that we need to worry about with Chagas disease. There's actually bradyarrhythmias too because of the intense fibrosis of the His-Purkinje system. So patients can need pacemakers. I will say parenthetically that there's a lot about this disease that's very similar to sarcoidosis. So as you're sort of thinking about this, the kinds of things you worry about with sarcoid, you might also worry about with your Chagas disease patients. Okay, so what does Chagas disease actually do to you? Well, what I'm going to describe to you is a clinical illness called the acute phase, which tends to happen in children. These are kids who live in infected houses with infestations, and they may get bitten over and over and over again during childhood. So very frequently, my patients can't say to me, oh yeah, I remember the time I had Chagas disease, because in fact, they were multiple times. It's a very non-specific illness, and actually in most people it's really clinically unnoticed, can last about 6 to 8 weeks, tends to have fever, other non-specific signs. This gal here has something called Romaña's sign, happens in about 10% of patients who have acute Chagas disease. She got infected fecal material into her eye, and this is a painless edematous reaction of the palpebral mucosa that is thought to be pathophysiologic of pathognomonic of Chagas. Very few people will actually have a clinically important presentation, which can include myocarditis and meningoencephalitis, and it can be fatal in about 10%. And at this point, if you looked in the blood of a patient, you would find parasites, and if you treat them with antiparasitic medication, it's thought to be curative. What's interesting, though, is that there are actually other acute presentations. I will say that unless you are a remarkably astute and lucky clinician practicing in the desert Southwest, you are very unlikely to see that form of acute Chagas disease. You might, however, see some of these other kinds of an acute illness, including congenital Chagas. Although most babies are born asymptomatic, they can be born premature with hepatosplenomegaly, anemia, and hydrops. There's also reactivation disease, and this can be either because of a disease-induced immunosuppressive state like HIV, particularly AIDS with CD4 counts of less than 200, or because of medication that we might use in a transplant setting. These patients can have meningoencephalitis, they can have cardiac disease, and the patients who are having transplant regimens can have a paniculitis, which looks a lot like a cellulitis, and if you biopsy it, you'd find trypanosomes. Oral disease, maybe you might see if you have a returning traveler who went to the north of Brazil to the beach, drank some acai juice or some sugarcane juice that hadn't been pasteurized and that also had ground up bug inside of it. They get a very high parasite load to the gut, and this is actually a clinically significant illness that has a worse outcome than the other kinds of acute diseases. And then what's interesting also is this is a disease that can be transmitted by transfusion. For the past few years, the FDA has mandated that every first-time blood donor in the United States, meaning all of you, if you've never donated blood before, will be screened for Chagas disease, and anybody who tests positive can no longer donate. In addition, most UNOS networks actually do screen for Chagas disease in their donor. Ours does, which is great. Unfortunately, it's not 100%, and there was a patient who received a cardiac allograft from a patient who had Chagas disease that was unknown and unfortunately succumbed to fulminant trypanosomal sepsis a few weeks later. So we have to keep that in our mind, although we're pretty much buffered from that here. Okay, so that's the acute disease. Now, anybody who hasn't received antiparasitic therapy go into the indeterminate phase of the disease. This is going to be about 90% of patients. Why do I say 90%? Well, there are some people who are going to leave the acute phase with cardiac damage, and those patients really already have chronic Chagas disease. Indeterminate phase are people who will test positive for antibodies against the trypanosome, but don't really have any end organ manifestations of disease. So the way that we define this is with positive serology. And this is a little tricky because if you order Trypanosoma cruzi IgG, which would be the test that you would order in MedConnect, you'll get back a result of one test. It's an ELISA that's run by every commercial lab in the US. The problem is you can't give somebody the diagnosis of Chagas without 2 tests coming back positive, and the only place we can get that now is at the CDC. So you test your patient with the commercial lab, that test comes back positive, you then have to send blood separately to the CDC for confirmatory testing. The good news about the indeterminate phase is that it's the end of significant manifestations of Chagas disease for 70 to 80% of patients who are infected, which is fantastic. But the bad news is that 20 to 30% of people will progress to the chronic phase. I put this guy on here just because he is having a very interesting test for the presence of T. cruzi infection. He's having something called xenodiagnosis. So he's got these cups on his arms that actually have laboratory-bred triatomine insects in them, and all of them are feeding on him. And he doesn't look too upset about it, which I think is lends credence to the hypothesis that the insect bite doesn't really bother people too much. So those bugs are then taken back to the lab where they're fed chicken blood for a few weeks, because chickens don't get Chagas disease. And then when the insects are sacrificed and the contents of the intestines are examined, if there is a parasite inside of it, it means it came from this guy. So that would be his testing positive for Chagas disease. We don't do that here. I don't think you can order that from LabCorp request. But so what is the clinical course of the chronic phase of disease? So this presents about 15 to 30 years after the time of likely infection. And as we've already discussed, these are patients who are generally infected in childhood. So this could be a young adult. It could be somebody in their 20s, 30s, 40s, 50s, sometimes older than that, but young relative to some of the other cardiomyopathy patients that we see, particularly our ischemics. And the reason why I want to hammer on that point is that you guys know now, you look at an echo of somebody who's got an ischemic cardiomyopathy, you're likely to see scar. Not always, but you're likely to see scar. Well, if you're looking at a heart that's got scar in it and that patient's too young for coronary heart disease or they don't have it, you should be thinking about Chagas disease or sarcoid. But in any event, so who progresses and why, we really don't know. I put up on the screen some of the things that people think about. Is it the degree of parasitemia? Men have more significant disease. Is it because they do more manual labor while they have this lymphocytic myocarditis? Who knows? Reinfection rates, strain type, genetic factors in the immune response. At this point, people don't really have an understanding for that. GI manifestations, I will mention only in passing in that they are less common and they tend to be associated with South American parasite strain. So it's going to be more common, say, in a patient from Brazil, Bolivia, or Venezuela. And most of the patients that we are going to see are not going to be patients from who are in that risk area. So what are the symptoms of the chronic phase of Chagas disease? So angina-like chest pain from microvascular disease, exertional intolerance, either from chronotropic incompetence or because somebody's got heart failure, palpitations, syncope from autonomic issues, bradyarrhythmias and tachyarrhythmias. The asterisk is to remind you again that this is something that can happen in patients who have normal or near normal ejection fractions. So we have to worry about these patients differently than we do many of our other cardiomyopathy patients. Heart failure from LV and or RV dysfunction, and stroke because of this apical aneurysm that we've talked about and because of higher rates of atrial fibrillation. Again, another asterisk, because again, we have to think about this in patients who have more normal ejection fractions than what we usually worry about. Causes of death, 50% sudden cardiac death, 40% heart failure, and about 10% an embolic event. So my patient was confirmed positive for Chagas disease. What do I do now? Well, we've already talked about the fact that what we're looking for is an abnormal EKG. And that's the first test that we're going to do because it's the main diagnostic criteria for chronic phase. So chronic phase of the disease is at a minimum testing positive for presence of Trypanosoma cruzi IgG with confirmation, and then an abnormal EKG. And what we're looking for are signs of the kinds of pathology that we've already looked at. So sinus node dysfunction, PR prolongation, right bundle branch block, left anterior fascicular block. The textbook EKG for Chagas disease is bifascicular block, heart block, and PVCs. And this is just an intensely arrhythmogenic illness. So huge meta-analysis, 49 papers, 34,000 patients, about a third of whom had Chagas disease. These are the findings that really shake out as being strongly associated with Chagas cardiomyopathy. We've already talked about almost all of them. One of the reasons that I put this up here, though, is to remind you that just because your patient doesn't have one of these EKG findings does not mean they don't have Chagas disease. And I realize I have to say this because I'll give this talk sometimes and people will come up afterwards and say, well, I had a patient, but they didn't have bifascicular block, so they didn't have Chagas disease. It's really not true. It's just if your patient has bifascicular block, you should particularly think about Chagas disease. So while it's nice to know these EKG findings, the definition of Chagas cardiomyopathy is positive serology and an abnormal EKG. That's all it is. It doesn't have to be on this list. So these are two centers. This top one from Brazil, this bottom one is actually the Paradigm and Atmosphere Heart Failure Aggregate Database that compared EKG findings in patients with Chagas disease right here, with patients with non-ischemic cardiomyopathies here, and then the Paradigm Heart Failure Atmosphere also had ischemic cardiomyopathies. And this is just going to really reiterate what it is that I just said to you, which is the Chagas patients, 50% of them had bifascicular block. Down here, 24%. But 10% of them had left bundle branch block. So it doesn't mean that you can't have Chagas disease if you have a left bundle. And unfortunately, like left bundle for many other etiologies, left bundle is a marker of advanced myocardial disease. So the flip side is true here. Only 5% of the patients with bifascicular block were found in the non-ischemic group, and down here 7 and 9. So what that means is if you're looking at a patient with a cardiomyopathy and they have a right bundle branch block, you really should be thinking about A, Chagas disease if they're in a Latin American and from a Latin American endemic country, or interestingly, and as I've already said, sarcoid, which is the other illness that really is likely to cause that kind of cardiac conduction system disease. Okay, so the next thing you might do if your patient has an abnormal EKG is a Holter monitor. If you don't have symptoms and you have a normal EKG, you probably don't need to have this done. If you do have an abnormal EKG, you would do this to look for any subclinical signs of worrisome arrhythmogenic events, i.e. non-sustained VT or bradyarrhythmias. There is a general recommendation to do exercise testing. Why? Because this is an arrhythmogenic illness that is actually provoked by exertion. And the reason that I put Lionel Messi up here is for a few reasons. One, he's pretty awesome. Two, he has a foundation in the north of Argentina that actually works with Chagas disease, kids with Chagas disease, so he understands the problem. But three, because there's a really bad joke in Bolivia that you actually needed to have more than a couple extra players on your soccer team if you were going to play a game, because one of them was certainly going to die in the middle of the game, and that was because of Chagas disease. So the other things you can see on exercise testing, though, is chronotropic incompetence because of the sinus node dysfunction that patients have. All right, now to switch to imaging, because I'm an imager and you guys are all imagers too now. So there actually are guidelines or recommendations about what to do in patients with Chagas disease that was chaired by our own Federico Ash. And I had the pleasure of participating too. It was really fun. So let's talk a little bit about the kinds of imaging modalities that were in this. The first is echo, as it always should be. I'm sorry, this is a super busy slide and I need to figure out how to make it better, but there are lots of things that I want to tell you about. One is that there's actually a classification system for sort of stage of Chagas disease. A is patients who have normal EKGs in the indeterminate phase. These are patients at low risk for VT and stroke, and at this point, we generally feel like they're doing pretty well. Now, one of the reasons why I wanted to focus on this right now is because Calvin may remember this. I don't know if I ever did this to you, Calvin, but I used to sit in the echo lab and say, look at an echo with a fellow and the patient's name indicated that they were from a Latin American country. And I would turn to the fellow and say, could this patient have Chagas disease? And if the echo were normal, the fellow would say to me, no, they don't have Chagas disease. Well, I didn't ask if the patient had Chagas cardiomyopathy. I just asked if the patient had Chagas disease. So the most common echo finding in somebody with Chagas disease is going to be a normal echo. If you have Chagas cardiomyopathy, maybe your echo is going to be abnormal. But most patients, remember, 70 to 80% of patients are probably going to have normal echoes. They still could have Chagas, and it actually still matters. And I can talk with you about that later. But let's move on now to some of the findings that are associated with the cardiomyopathy. So in terms of the rest of the grading system, we've got stage B, which is abnormal EKG or abnormal EKG and abnormal EF, but no symptoms. C is abnormal EKG, abnormal EF, and symptoms, and D is class 4 heart failure. And why we review this is because you can see the staging up here, A, B, C, D, and you can see that these are some of the findings that people have with Chagas disease, and we're going to look at the relative rates of them relative to what their clinical stage is. So the first is the left ventricular apical aneurysm. I'm going to show you an example of this, actually more than one. What you can see is that if somebody's in stage A and stage B, they don't have a 0% risk. And it's unfortunately true that even if they're A with a normal EKG, they still also have a small risk of having an apical aneurysm. It's why I feel like we really ought to be getting echoes in all of these patients. Same thing is true for that posterobasal lesion that I showed you as well. Small rates of it in patients who are very, very incipient disease. What you will see is as the disease progresses, you see more and more rates of these focal wall motion abnormalities. And again, reiterates the fact that this is an illness that is often accompanied by scar. And if you see a patient who has a cardiomyopathy with scarring from Latin America, you need to think about Chagas disease. Okay, that's what I wanted to talk about there. So this might be an echo of somebody where I would turn to the fellow and say, does this patient have Chagas cardiomyopathy or Chagas disease? And the fellow might say no. Well, this is actually a tricky one. So this is a patient who was 27 years old when this echo was performed. He presented to Georgetown because he was having palpitations. He was an immigrant from El Salvador who worked as a construction worker. He got an EKG, which showed bifascicular block, and then got this echo. And I think one of the things that we might say, if we're being a little nitpicky about it, is that we're not 100% sure we're actually seeing the true apex. Maybe this is a little foreshortened, but most of us would feel pretty comfortable saying that this ejection fraction is normal. Well, because of his abnormal EKG, bifascicular block in a young man, it was suggested that he get a cardiac MRI, and he did, and I'm not going to tell you about the findings because I'll show you in a minute, but he then became lost to follow-up and unfortunately presented 2 years later with a massive MCA stroke, at which point he had this echo done with echo contrast. And I'd like to call your attention to this very, very focal ball of contrast at his apex. So this is a classic Chagas punch hole apical aneurysm. And what you can see is, again, this is a young man who had a catastrophic stroke with normal ejection fraction and this very, very focal abnormality, which was not obvious without the use of echo contrast medium. So one of my big take-home points for you is, if I've implanted the seed and now you're thinking about Chagas disease and you're reading an echo on a patient who's from Latin America and they've had a stroke, make sure you've imaged that apex well. And I think that requires contrast. And if you can't see it well, it requires an MRI. So those are just my 2 cents there. Okay, so moving along, MRI, here we are, MRI and Chagas disease. So many studies have shown association of LGE with Chagas cardiomyopathy. Unfortunately, again, patients with normal EKGs can have focal LGE, and the significance of that really isn't known, but it can be up to 40% of patients studied. What we know is, like other diseases, other non-ischemic cardiomyopathies with LGE associated with them, that the magnitude of scars associated with worse outcomes. And so there's a question of whether or not there's a role in risk stratification for defibrillator placement, which I think is particularly important in some of these diseases where we see scar, but the patient's EF is not low enough to make us automatically think about them for primary prevention. So we think about hypertrophic cardiomyopathy, we think of sarcoid. So I feel very strongly that Chagas should fit into that rubric. I cannot point you to a paper that proves that, but that's my stump speech about it. Okay, so this was an interesting paper. There were actually 2 Chagas MRI papers that came out in this journal, in this specific journal of JACC. And again, what I want to reiterate is, just because LGE is common with Chagas patients, the absence of LGE does not mean your patient doesn't have Chagas. So 71% of patients in this study, these were all patients with cardiomyopathy, had scar. It was mostly inferolateral. But as I mentioned, not all patients with bad EFs had scar. Bifascicular block and PVCs were EKG findings associated with scar. And the scar can be a variety of different shapes and sizes. It can be subendocardial, it can be subepicardial, it can be transmural. There's a lot of different ways that you can see it, so no one classic finding. Okay, so this is the MRI from the patient we were just talking about, the 27-year-old man. He had this, and this apical aneurysm was present on this case. And you can see the LGE on this next one. I throw this one in here because I think it's really awesome. This is a patient, I mean, not for the patient. He's a 45-year-old Mexican immigrant to Chicago, and our former colleague, Anu Rao, read this MRI after he had sudden cardiac death and called me and said, do you think this guy can have Chagas disease? So he has like a hammerhead shark aneurysm and tested positive for T-Cruzi IgG. Okay, so now just to shift away from imaging, we're going to talk very briefly about the prognosis. Unfortunately, it's bad. It's bad in the way that, say, sarcoid is too. Like, we know that there's some of these cardiomyopathies that portend the worst prognosis, and it's probably because of the scar that's killing people who don't have abnormal EFs. But setting that aside, this is from the Paradigm and Atmosphere database again. And what was remarkable about this particular set of data is that these patients were part of a clinical trial and were getting phenomenal guideline-directed medical therapy. So it's not that these patients weren't getting treated well, they were being treated exceptionally well. And you can see that these Chagas patients, who are the line in red, die more than both the ischemics and the other non-ischemic cardiomyopathies. Okay, so what do we do to save our patient from this terrible fate? So the first thing you might think about is, this is an infectious disease. Should we use antiparasitic therapy? I'm going to move through this pretty quickly. There are 2 FDA-approved medications. The bad news about them is that they are really unpleasant to take, require incredibly careful monitoring, and particularly with benznidazole, which is basically the standard of care, can cause a Stevens-Johnson-like skin reaction. So really bad. So what's the data to support using it? Well, for children, there's actually pretty strong data. Randomized trials show that there are cures in 65 to 90% of children who take this medication, depending on the age when it's administered. Why did I do cures? Because cures means that they seronegativized, or their PCR evidence of infection went away. Not that there have been any long-term studies that have proven that these children now no longer develop cardiac disease. I think that's pretty important, but it's not getting done. There is observational data, only observational data, but it seems like there's really impressive reduction in the risk of transplacental passage if you treat a mom before she's pregnant with benznidazole. There are prospective trials suggesting a decrease in risk of progression associated with treatment in adults. Unfortunately, this B1 study upon which people focus when they talk about this was dreadfully performed, so I think we really probably shouldn't even talk about it. And serologic cure, as we were discussing, is much less frequent and can take decades to occur. So the role for antiparasitic therapy is very murky, although consensus statements from experts in the field suggest offering therapy to patients up to the age of 50, with a question of age 50 to 60 if they're in the determinant phase. What about in the patients that we might see in the hospital? So patients with cardiomyopathy. Well, this is a situation in which there's randomized trial evidence. There was a study called the BENEFIT trial that randomized 2,854 patients to benznidazole versus placebo. The mean age was 55. And this is important because, for instance, our 27-year-old patient was 2 standard deviations below the mean age. Does this study apply to him? I don't know. Why does it matter? Well, because at 5 years and even at 7 years with phenomenal follow-up, there was no benefit in rates of hard cardiac endpoints if you were administered benznidazole versus placebo. And this is in the setting in which there was a dramatic decrease in positivity of PCR associated with treatment. So there are a lot of caveats about this study, but at the same time, it is a well-done randomized trial that suggests that there's not much of a role for antiparasitic therapy in a patient with established cardiac disease. The way you got into this trial parenthetically was having at a minimum 2 EKG abnormalities, but the vast majority of the patients were in fact in class 1 and had normal ejection fractions, so they weren't particularly sick. Okay, so what can we do if we can't treat the parasite? Well, these are 2 nice reviews. Happy to send them to you if you want. Basically, it's GDMT with the caveat that there's not a lot of trials that actually included a robust number of patients with Chagas disease or studies specific in the Chagas population. Any of the Chagas trials either were non-randomized or they're very, very small. So it's extrapolation, but so be it, that's what we've got. The one thing I would say is that beta blockers have been specifically studied in a randomized trial, partly because there was concern about exacerbation of bradyarrhythmias, and it seems to be, it definitely is an issue. You can see, say, in the Paradigm Heart Failure database that fewer of the patients actually were on optimal doses of beta blockers. That's in part because so many more of them are on amiodarone because of the VT issues, and these are resource-poor environments where defibrillators are hard to come by. So interesting about amiodarone, though, is that it may actually also have antiparasitic activity. It's an ergosterol synthesis inhibitor, so there are some randomized trials looking at amiodarone as a primary treatment for Chagas cardiomyopathy. So what else do we need to do? Well, I've been talking a ton about arrhythmias. So what can we offer patients? Pacemakers, defibrillators, resynchronization, and VT ablations. So pacemakers, it's going to be standard indications for pacing. Defibrillators, interesting question. So there is actually a class 2A recommendation in the ESC for putting a primary prevention defibrillator in patients with EFs less than 40%. The language about Chagas disease was removed from the HRS-AHA guidelines at this most recent iteration, which is unfortunate. So right now it's sort of an evidence-free, guideline-free zone, which is why I caution people that I think they ought to take this very, very seriously and think about doing more aggressive evaluations in patients who have Chagas cardiomyopathy, particularly focal wall motion abnormalities, even if their EFs aren't bad, including Holter monitoring, including potentially EP testing, including cardiac MRI. The reason this patient on the right is an example of why I feel so strongly about this. This is a guy who We saw in the consult service in March of 2018, 45-year-old El Salvadorian immigrant who was working at Popeyes. He lifted a bag of potatoes and went into VT. And fortunately, there was a policeman waiting online for his French fries who was able to defibrillate him. And he came to the hospital. His first EF was terrible, as they often are after you've had sudden cardiac arrest. But about a week later, he had this echo. Now, I haven't showed you the whole thing, but it's really not that bad, right? So you're not going to look at this first parasternal and think that's a patient who needs a defibrillator. But boy, did he need a defibrillator. So this guy haunts me, and I'm hoping that you'll keep him in your mind as well. Leave aside resynchronization, VT ablations. The only thing that's kind of cool about VT ablations in Chagas is both that they work, but also that because of a bizarre association with epicardial VT circuits, this is the disease process for which epicardial VT ablations was actually designed by a Brazilian electrophysiologist. All right, so what next? Anticoagulation. So we've already talked a lot about the apical aneurysm, people with EFs that are almost normal or normal having strokes. Well, in this patient here, who is another patient that I think Dr. Valdivieso saw on consults, is a patient who's got a pretty bad EF, and you can see obviously that she's got a big blob at her apex. She came into the hospital parenthetically for heart failure, not for stroke, but was found to have had multiple strokes in the past. She's pretty easy, right? You know you're going to give her anticoagulation. But what about that guy that we saw before, the 27-year-old? Well, he's really tricky, right? Primary prevention anticoagulation in somebody who's 27, construction worker. If we'd actually seen that, it really associated that apical aneurysm with Chagas disease, would we have put him on anticoagulation? Well, I can't tell you there's great data about it. There is something that's kind of like the CHADS-VASC system, scoring system. It's called the IPEC score. It's a single center derivation and has not been independently validated. It's got some problems with its methodology, but at the same time, it is kind of the only thing that we have, which includes a point scores, two points for LV dysfunction, 1 for age 48, 1 for apical aneurysm, 1 for repolarization abnormalities. So this kid would not have actually received a point score of 4 or 5, which is the threshold to which the benefits of anticoagulation outweighed the risks of bleeding in that patient population. And obviously, they were all on warfarin. Might have put him on an aspirin, you know, probably would have been the right thing to do, but it's not clear whether or not that would have impacted his event. But anyway, this is something that haunts me, and it's why I really feel like we need to focus on the apex in these patients, particularly actually in the patients with heart failure who have bad EFs. And I cannot tell you actually how much chagrin I feel as an echocardiographer, feeling like I've looked at an echo, I've looked at the apex, I feel like we've done a great job imaging it, only to find when somebody does a V-gram of all things that we've missed an apical aneurysm. So it's why I feel like echo needs to have contrast and also think strongly about alternative imaging modalities if in fact it would change your management, and it might. Maybe if you have a patient who's over 48 who has a bad EF, if they have that apical aneurysm, you might consider giving them primary prevention for stroke. Okay, so this last echo that I'm going to show you is a patient. I was in the OR with this guy who was I think a Bolivian immigrant, and the day that he got his LVAD is the day that he was diagnosed with Chagas disease. So these are patients who can benefit from advanced heart failure therapy, including LVADs and including transplants. So the great news about transplant is that these patients tend to do well because they're younger and have less comorbidity. The bad news is that reactivation happens. You know, it's a parasitic illness. It's still in the person's body. And the CDC, who's monitored the vast majority of the Chagas transplants in the United States, where people knew that the patient had Chagas disease, they're at 60% rate of reactivation. The good news is that we define that as PCR positivity that gets lower cycle thresholds from 1 week to the next, which means we're not waiting for somebody to have a clinical event. So we jump on it, we give them benzimidazole, and they tend to do very well. All right, so now I'm going to try very briefly, I'm sorry, I'm going to overstay my welcome, to convince you that you actually really are going to see this at Washington Hospital Center. So when you hear hoofbeats, I want you to think about zebras, horses, zorses, I don't know. Okay, so you might tell me you've never seen a case. I'm actually going to just blow through this and go straight to the US seroprevalence data that I hope will prove to you that you have seen a case. First of all, Heart failure clinics have actually looked at the prevalence of Chagas disease in their Latin American immigrants. So in Los Angeles County, looking at patients who had ejection fractions less than 40% and non-ischemic cardiomyopathies, 18.5% of those patients studied had Chagas disease as the cause of their cardiomyopathy. Similar population with EFs less than 45. At Elmhurst in New York, 13% had Chagas. Back in LA County, looking at immigrants from endemic countries who had bundle branch blocks on their EKGs, 5% had Chagas. 18% did if they had bifascicular block, and 7.5% of pacemakers, not defibrillators, had Chagas. So the LA group, Chiba Maimandi, screened about 4,800 people in a community-based program. They found a total seroprevalence rate of 1.24%, 3.5% are from El Salvador. Similar process at a primary care screening event in East Boston, screened, now they've actually now done about 8,000, but with their first 5,000, about 1% positive. What about in DC? Well, we have about 1 million people who identify as either being Hispanic or Latino for the American Community Survey. And DC has a higher average rate of foreign-born Hispanics than many other places in the country. And this matters because those are the people who are really at risk for Chagas. The crazy thing about DC is that we have a very high per capita rate of Chagas disease because of the countries of origins of our immigrants. So our predominant country of origin is El Salvador. Also other Central American countries that have higher rates of Chagas than, for instance, Mexico, which is where most of the Los Angeles County immigrants came from. But we also have little Bolivia and Northern Virginia, and those patients have crazy high rates of Chagas disease because for whatever reason, they tend to come from areas of Bolivia where Chagas disease is highly prevalent. We actually have data. So the nonprofit worked with Johns Hopkins on a seroprevalence study. We screened 1,500 patients in the DC area, found about a 4% seroprevalence rate overall, 2% from Central America, and 22% of South Americans, which is likely from Bolivia. Almost all of them were from Bolivia. Okay, so a couple of frequently asked questions to end with. I would say that when I speak with cardiologists about this, by and large, the most common question I get is, I saw this bug in my house. Do you think I could have Chagas disease? So kind of missing the point that we're talking about Latin American immigrants, but people want to bring it close to home. So in fact, it turns out you could get Chagas disease in Maryland. I don't know if in DC necessarily, but you could in Virginia. It's just really unlikely. The rates of transfer of parasite and the likelihood of being bitten by an insect are very, very small. We could talk about that more later. More important questions is, why should I bother screening if the medicine won't help? People focus on the fact that benzimidazole won't help. Well, we already have talked about this. Bad things happen when people have normal or mild LV, normal EFs or mild LV dysfunction, stroke and VT. You might want to know about that. If a patient gets transplanted, you need to monitor them for reactivation. And if the patient's female, the kids need to be screened. But all relatives of an index patient are at higher risk, about seven times higher risk, about 7%. So what I want you to do now, I want you to remember this. I'm not there to nag at you anymore. Boy, did I used to nag. Gabby and Christy can tell you how much I used to nag about Chagas disease, but I'll try to nag through them. So you see a patient with an EKG abnormality or an arrhythmia that makes you think about Chagas disease. If they're from a Chagas-endemic country, test them. If they have an abnormal EKG or MRI findings, test them. If they have a cardiomyopathy, test them. And honestly, you should think about it in any patient who's from a Chagas-endemic country in Latin America. And I'm always happy to answer any questions about it that you might have. This is a nice flow chart from one of the JACC article. And thank you for your attention today. And I will stop talking and see if you have any questions.
Thanks. I had a quick question about, do you try to, you talked about if the EF is normal, but you see clear wall motion abnormality or they have some arrhythmogenic focus, do you try to, have you sent those folks for an EP study to see if they can, is that how you're able to get a defibrillator in them, or what has been your experience?
Yeah. So,
sorry, that's just overhead.
Oh, okay. So the answer to that question is that is, I think, exactly what you should do. What was interesting is that most of the time that I was making the diagnosis in the hospital center echo lab, these patients already had whatever significant clinical presentation they were going to have. So they either already came in with their VT, and there have been another couple patients like that there. So it was pretty easy because it was already a secondary prevention issue. But as I've talked with the Chagas community about it, that is what people think you should do. MRI, actually, I think being a really important part of the evaluation, because like other diseases, if the people reach a threshold, X and such gram scar burden, you'd want to think about that and maybe have a study. We have a huge problem here, which is that most of these patients in the DC area are uninsured. And if they get admitted to hospital center, unfortunately, what tends to happen is they leave and then often not eligible to return to hospital center clinics. So what I also try to do is to get as much of the evaluation done while they're an inpatient as possibly can, because once they're gone, they can be lost to follow-up or they're sort of scattered to the winds. Anyway, so yes, I think it's an exceptionally good idea to try to do aggressive risk stratification in those patients, Holter monitoring, MRI, and EP study if you're finding abnormal findings that are worrisome there, to try and push somebody to do a primary prevention defibrillator. Has anybody seen Chagas yet?
Yes.
Who's that?
That's Vinay. I'm one of the first year fellows.
Yeah?
Yeah, this was a patient who came in after a VT, had right bundle and left anterior vesicular block. I forgot how old he was, but he was in 30s, I think.
Uh-huh.
And at that time, he had advanced cardiomyopathy already. He was started on inotropes. I haven't seen his follow-ups, but yeah.
Good. Did he come in with the diagnosis already, or did you guys make the diagnosis?
No, yeah, the serology was sent. I think he was also from either Bolivia or El Salvador, I forgot, but we got the serology after.
Okay, so you have to remember though, and first of all, fantastic for thinking about it, way to go. Have to confirm. If it's a Bolivian patient with that kind of a story, so obvious they have Chagas disease, but you really can't give somebody the diagnosis until you've done confirmatory testing. The problem is it's a royal pain in the behind, but I'm happy to walk you or whoever through it because it involves hand carrying blood down to the lab and then they send it to the CDC. But yeah, that seems like a fantastic case. Great, good for you. Anybody else? You all have, I know you have. Tell me, if you make the diagnosis, please tell me. I'll be very proud of you, but I also love to keep an eye on what's going on around here and to learn, because one of the things that's true, I like to joke, in the land of the blind, the one-eyed woman is queen, and I'm the one-eyed woman in this scenario. So not many people think about Chagas disease here, but what's very clear is that compared to people in, say, Argentina or Brazil who think about this and see this disease over and over and over again every day, our body of knowledge is really still growing here in the US. So I like to learn from every case. So I'm happy to discuss any questions you have about it. If you're thinking about testing a patient, help you make that decision, the answer is always going to be yes, unless they're not from a Chagas-endemic region. But so. Okay.
Thanks very much.
Nice to meet you all.
Thank you.
Thanks.
No, it's great.
All right, bye.
Bye, thanks.